Good morning, everyone. Thank you for joining us for today's webinar on the topic of the public health risks of counterfeit pills. And I know we touched on this with Dr. Lewis Nelson back in January, and are continuing to explore this topic today. Such an important emerging, continuing to emerge, right? Issue with this evolving opioid crisis. And we're so glad to have our expert speaker with us to discuss today. A little bit of housekeeping. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacist claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. And this webinar has been approved by NJOEMS for one EMT elective CEU. And the Partnership for a Drug Free New Jersey is approved by the Board of Certification Inc. to provide continuing education to athletic trainers. And this program is eligible for a maximum of one Category A hour or CEU. PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon and Johnson & Johnson, and all other planners, faculty, reviewers have no relevant financial relationships to disclose, and all relevant financial relationships have been mitigated. If you wish to claim CME or CE credit, you must do so within 30 days from today's date. And after that time, we will no longer be able to issue you credit. You'll see the information at the end of the webinar on the screen on how you can access that credit. Today's webinar is jointly provided by the Partnership for a Drug Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative and Community Responses, and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them all for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. And I'm so pleased to welcome today's expert faculty, Dr. Joseph Friedman. He's a resident physician and substance use researcher in the Department of Psychiatry at the University of California, San Diego. And he's joining us this morning from the West Coast. And so we appreciate you joining us here on East Coast time, Dr. Friedman, and look forward to your presentation. I will turn the meeting over to you.
Wonderful. Good morning. Thank you for having me.
Yes, thank
Okay. Can you see my slides all right?
Yes,
Fantastic.
they look good.
So I'm going to be presenting today about the public health risks of counterfeit pills. Just for everybody's reference, throughout the talk, if there's some data that you're interested in taking a deeper look at, most of the time, if the data are available or if an article is available, I've placed a QR code next to the graph. So you can open up your phone camera, take a picture, and you should be able to access the data or the paper that way. So the talk that I'm going to give today is based on this article that came out in the Lancet Public Health that I wrote with a colleague of mine, Dr. Dan Ciccarone. It came out last year, called The Public Health Risks of Counterfeit Pills. And in this article, we basically kind of highlight a number of the ways that we think that the rise of counterfeit pills is actually driving some really unique and unfortunately kind of harmful changes in the overdose crisis and the kind of addiction and mental health crises across the United States. So first, before we can understand the importance of counterfeit pills, we need to kind of understand some of the big shifts that are happening in the overdose crisis, because I think that explains exactly why we're so worried about counterfeit pills. So I think probably most people in the audience have a sense that, the overdose crisis in the United States is really bad, right? It's a huge kind of tragedy that's occurring in our country. But I want to make the point that really the United States is an extreme outlier on the global stage when it comes to overdose death rates. So here's some data only updated through 2019 from the Global Burden of Disease study, but it shows the top 10 countries globally in terms of overdose death rates per capita or per, the number of people in the country from 1999 through 2019. So these are the top 10 countries. And what you can see is that up until about the year uh, 2000, the US had a relatively high drug death rate, but it was somewhere in the pack of with these other, potentially peer countries that we could be comparing ourselves to. But around 25 years ago, we really started to pull away from the pack and became kind of by far the global leader in the overdose death rate. So when we think about this crisis in our country, we should recognize that this is really uniquely bad for us, more so than other countries. When we kind of understand trends in the kind of long-term trends in the overdose crisis, there's this concept of exponential growth, which is really important. So on the left, what I've plotted here is basically the overdose death rate here on the y-axis over time from 1980 all the way through 2024. And we kind of plot these dots over time. And there was a very famous paper that came out in 2018 in the journal Science, where a few authors showed that, these death rates from 1980 to 2016 can actually be perfectly explained with an exponential growth curve. And this is really unusual when we look at causes of death. Most causes of death either go up slowly or go down slowly. And really, the only times we see these kind of exponential growth curves, usually in public health, is like an epidemic, COVID-19 pandemic, or, something really dramatic like that. But actually, for the past almost 50 years, overdose deaths in the US have followed this exponential growth curve, which would be more typical of like a big infectious outbreak or something. So it's pretty unusual. And then this graph is actually from a forthcoming paper of mine where we show that, really over the past couple years, if anything, we've been above this exponential growth curve due to outbreaks of synthetic substances, synthetic drugs here. And then in the context of the COVID-19 pandemic, we've actually been above exponential growth. And really, just over the past year or two, we finally started to dip down, and it looks like we're starting to drop below the exponential growth curve now, which is very good news. But you can see that compared to where we were in 1980, there's still this vast gulf of mortality happening every year. And despite this relatively smooth increase, this kind of march year after year up in an exponential fashion, when you actually look at the component drugs that are driving deaths in any given part of this curve, they go up and down, and actually they're quite noisy. So you can see that over time, a very different set of drugs has kind of contributed to the overall overdose death crisis. We'll talk about some of them today. And so this is kind of important to keep in mind that despite this overall phenomenon of exponential growth, in any given decade, things have looked very different in terms of which drugs are most responsible. So when we talk about the past 25 years in particular, which is really when the period that the US became this kind of unique global outlier, we like to use this four waves paradigm to sort of generally understand in broad strokes what was happening in the illicit drug supply that was driving deaths. So you can see wave one here in green. And again, I'm plotting the overdose death rate per 100,000 people on the y-axis. And then on the x-axis here is just time. So it shows the progression of time. Here we're looking at deaths involving prescription opioids, and we've removed the influence of fentanyl. So this is only involving prescription opioids without fentanyl, because that kind of muddies the picture later on. So what we can see is that this wave really began in the early 2000s, started to uptick much more strongly around 2010, reached a peak in 2016, and has been declining ever since. So there are still some deaths involving kind of authentic prescription opioids, but it's relatively small in terms of the overall piece of the pie that it represents. Then we can see heroin here. This is wave two. This really started to rise in 2010, peaked in about 2015, and now heroin-involved deaths are very, very rare in the United States. Still happen, absolutely, but a very small piece of the picture. Wave three is usually shown this way, which is fentanyl without stimulants involved. This started to go up in 2013. You can see peaked here in about 2021 and has been declining ever since. And overall had a much larger kind of magnitude than the amount of deaths caused by either of the previous waves. And then finally, this is wave four. So this is the wave that we're in right now. And this wave can be defined as kind of polysubstance or multiple drug involved deaths. It's easiest to graph it by showing the combination of fentanyl with stimulants. And certainly that is the most frequent combination, probably the most important combination we see. And you can see this has had kind of the biggest magnitude of any wave and has only started to go down in about the last year of data. But it's important to keep in mind that really, when we talk about the fourth wave, we're talking about fentanyl being added to, or a number of things being added to fentanyl, fentanyl being augmented with other kinds of synthetic substances. And stimulants are a very key part of that, but it's not just about stimulants and fentanyl. Finally, it's important to note that despite the progress we've seen with overdose death rates coming down in terms of fentanyl-involved deaths, some parts of the overdose crisis are still going up. So deaths involving stimulants without fentanyl are still on the rise here, which I've shown in purple. And another emerging substance of importance, which I suspect many people are familiar with, which is xylazine, is also increasingly important. And so xylazine is a veterinary sedative, not approved for human use, has increasingly been used to augment or modify fentanyl, and that has been continuing to go up despite death rates from fentanyl going down. So kind of a very complex picture, but overall, what we can take away from the very latest kind of year here is the majority of deaths still come from fentanyl. Fentanyl is thankfully decreasing in terms of the overall death rate, but increasingly novel things are being added to fentanyl to kind of augment and modify it. So the big picture of what's happening in terms of the illicit drug supply, to kind of summarize across a lot of different areas, is we've really moved from a plant or agricultural derived illicit drug market to a synthetic illicit drug market. Now, some examples of that would be methamphetamine kind of overtaking cocaine as a dominant stimulant in much of the country. The Northeast might be a little bit of an exception in certain ways, but I think this is happening in the Northeast as well, in other ways. And then very clearly, heroin being completely overtaken by fentanyl as the kind of dominant illicit opioid that's available in the market. Now, when we think about the why that would happen, any kind of agricultural product is, labor intensive, requires numerous workers. Lots of people kind of have to be in on this, illicit or illegal activity. And generally, these substances are less potent. Like pound for pound by weight, they're usually a little bit less potent. Whereas synthetic substances require just, a handful of skilled workers, people with knowledge about chemistry. These can be made to be highly potent, meaning really easy to transport a very small amount, into the United States to generate the same amount of profit instead of transporting a large amount of an agricultural product. And for that reason, they tend to be extremely profitable. So here's kind of just to kind of help you visualize, we're moving from the poppy field, right, to this lab in Mexico, where like one person is able to create a huge amount of, illicit opioid in this lab. So, you know, when we talk about fentanyls, which is the dominant force in the overdose crisis, this is a family of short-acting opioids. They're relatively easy to synthesize, the organic chemists tell me, not my area of expertise, but not a very difficult thing, they say, to make. It's vastly cheaper than heroin to produce, and the MME, or sort of the relative potency compared to morphine, is usually measured at about 50 to 100 times more potent than morphine. But it's important to keep, for kind of base fentanyl, it's important to keep in mind that fentanyl is a family of medications, drugs, and some of the analogs are far more potent than that, and some can be less potent. So they can have very different properties depending on which specific fentanyl we're talking about. Most of the time, we're still seeing kind of fentanyl is what's being added. So here's some data about fentanyl. This is from Drug Checking Los Angeles, from their drug checking Viz tool, which you can access at the link here in the bottom left. And this is a group that I work with pretty closely. And the point that I want to make here is basically that the main driver of risk when it comes to fentanyl is really the variable potency. So we know that, in the hospital setting, when physicians and health professionals administer fentanyl, it's very safe because it's administered in a very precise amount. So the fact that it's 50 to 100 times stronger than morphine doesn't really matter because you're using very specific amounts in a very safe way. The thing is that in the illicit drug market, of course, we don't have the nice quality controls that we have in the legal, pharmaceutical market. And so we often see this kind of huge spread of potency, which is what drives risk for the end consumers. So this is a histogram. On the y-axis, it's just like the number of samples that this drug checking program found, and on the x-axis, we're seeing the percent purity of the fentanyl. This is people who brought in fentanyl. They expected it was fentanyl. They knew it was fentanyl. They're in Los Angeles, and they kind of gave it to the drug checking program, and the drug checking program did some analyses to find out what percent pure is it. And what we see is that although the average purity is something around 15%, right, which is still very strong when you consider it's 50 to 100 times stronger than morphine, there's this huge range, right, where a lot of people are getting fentanyl that's, between 0 and 3% pure, and some people are getting 40% pure, right? And so it's like you kind of walk in, it's as if you walk into a bar and you order a drink and you don't know if there's going to be like half a shot in it or there's going to be 20 shots in it, and you sort of have to start drinking it to see what happens. Is one way to kind of understand the magnitude of this degree of variation in the illicit drug supply. And this group has actually done some really nice work where, analyzing a number of different samples from like the same tiny little part of LA Skid Row on the same day, and they see this huge amount of variation. So a consumer walking around, the kind of open air sales points of downtown Los Angeles would not be able to necessarily reliably know what concentration, what purity fentanyl they're getting. So that kind of drives a lot of the overdose risk. Another thing that's important to keep in mind is that because fentanyl is so cheap and so available, we've also done some work showing that the average amount of opioid that is kind of hitting people's brain receptors has gone up a lot relative to previous waves of the crisis. So if someone shifts from heroin to fentanyl, the overall amount of opioid that they're able to pay for and use on a daily basis is going up, potentially tenfold or more, which has a lot of clinical implications. And then fentanyl has a much shorter half-life than heroin. So if people are injecting or smoking, it means they just have to do it more often to not get withdrawal symptoms. And that confers other health risks, right? People have to inject themselves more often, more risk of abscess, smoke something more often, more risk of lung disease, so on and so forth. And, because it's a synthetic product made in a lab, it really lends itself to combination with other synthetic things also made in a lab or bought on the dark web and kind of added in. So we're sort of, as we moved away from agricultural to chemistry world, we're kind of making it very easy for these, kind of chemical concoctions to be created, which is what I'm going to show you now. This is an example of how fentanyl has really magnified what we call polysubstance or kind of multi-drug use. Now, this is sometimes intentional, sometimes unintentional. So sometimes people are intentionally buying fentanyl and methamphetamine separately and using them together, smoking them, at the same time, so on and so forth. A lot of the time, though, it's actually unintentional, meaning you're trying to just buy an opioid, but what you get is kind of heavily adulterated or augmented or modified with other substances. So here we can see this is an example of why I think drug checking technology is so powerful, and this is a key interest of mine, is this is a sample from Chicago, sold just as an opioid, probably bought as like dope or fentanyl or maybe even heroin. But what it actually contained was fentanyl as well as several other fentanyl analogs that are different. It contained cocaine, it contained xylazine, a novel veterinary or sort of an emerging veterinary sedative, right? Not meant to be used by humans, contains some Benadryl, and and this kind of designer benzodiazepine that's related to Xanax, right? And so you can see like this incredible, polysubstance cocktail just contained in this tiny little amount of powder in this bag. And somebody who's purchasing dope would have no idea that they were consuming something which was such a kind of complex mixture of drugs. So into that context, we see the rise of counterfeit pills. And I think this kind of confers some, really uniquely kind of concerning aspects in the context of all the synthetic kind of evolution of the illicit drug market. So here's an example. Here's some photos from law enforcement just showing some authentic oxycodone pills versus counterfeit oxycodone pills that probably contain fentanyl or another synthetic opioid. Some authentic alprazolam versus some counterfeit alprazolam that probably contains a designer benzodiazepine, which could potentially be much stronger, or just have a non-standard dose, even if it's the same strength. And then authentic Adderall versus counterfeit Adderall, which probably contains methamphetamine, but could contain anything, right? So, as I've said, I think illicit opioids and other drugs are increasingly packaged in pill form. So, some evidence of that is comes from law enforcement seizure data, and recent analysis showed that the taking the overall weight of all the fentanyl that's been seized by law enforcement, that the percent rose from 10% of the fentanyl was in pill form in 2017. That rose about 50% in 2023. I would expect it's now more than half of all the fentanyl. And breaking it down by region, and here you can see a map of the percent of all the fentanyl represented by pills. It is a little more concentrated in the West Coast, but we know that this is kind of spreading all across the country. This is, of course, made possible by the rise of illicit or black market pill presses. Here's another photo from a law enforcement seizure. You can see this relatively simple machine. It just takes powder, compresses it into these pills, which I think pretty convincingly look like pills. And here is I thought this was a really interesting analysis or investigation by some journalists. The headline says, "We bought everything needed to make $3 million worth of fentanyl. All it took was $3,600 and a web browser." And so it's kind of showing how how the kind of synthetic revolution has really lowered the barrier to the production of a really large amount of synthetic opioid, right? Where these journalists, they didn't actually make any fentanyl, they didn't break the law, but they just wanted to show how easy it would be. They went on the dark web, they bought a pill press, they bought all these precursors, and they had all the pieces, for a relatively small amount of money to essentially open up a fentanyl production shop in the United States, right? So, the core kind of arguments that I want to make about counterfeit pills is that they increase the market for fentanyls, meaning people that would normally not try fentanyl powder may be willing to, knowingly or unknowingly be exposed to fentanyl when it looks like a prescription pharmaceutical. A really heartbreaking example of that is the increase in overdoses among children or teenagers. Here's an LA Times headline from a couple years ago. Students overdose death prompts urgent action among educators, police. I was, at UCLA at the time when this was occurring, and there was basically this outbreak of overdose deaths among teens at this high school in Los Angeles, due to, counterfeit pills, which I think helped kind of galvanize some attention to this issue. This is from an article we wrote in JAMA, kind of looking at this at the national level. And what we've shown here is, again, on the y-axis, it's the overdose death rate per 100,000. On the x-axis, it's time. And what we can see here is death rates for high school age teenagers, so 14-year-olds to 18-year-olds, death rates for a number of different drugs, right? Like how many teenagers are dying from heroin, that you can see in dark blue, how many are dying from cocaine, that's this other dark blue with white circles, benzodiazepines in orange, right? And so basically what we see is that, despite this kind of steady increase in overdose deaths for the entire country for the past 50 years, teenagers were really insulated from that for the vast majority of our country's history, which has been a really good thing. And it's really not until 2020, between 2019 and 2020, with the rise of counterfeit pills, that we see overdose deaths among high school age adolescents, shown here, due to illicit fentanyls started to spike considerably, right? And so we can see this line here at the top shows us something really unprecedented is happening with teenagers, right? And it's occurring right at the time when counterfeit pills are starting to kind of take off across the country. And what we show here in this follow-up piece in the New England Journal is basically a little bit more updated data showing the teen overdose death rate on the top. But then we actually kind of compare this to the percent of teens that report experimenting with illicit drugs besides cannabis, right? So we kind of remove that from the equation because that's moved around a lot in terms of policies and cultural practices. But just the percent of teens that by the time they graduate high school, they've tried a drug that's not cannabis. And that we're actually at historic lows in terms of that. Like far fewer teenagers are using drugs, which is great. And so the issue is not that teens are increasingly enticed to use illicit drugs. The problem is that when they do, the presence of fentanyl and synthetic drugs in pill form makes the decision to use an illicit drug much more dangerous than it was before. So we're seeing the market is more dangerous, but culturally speaking, people are not using more illicit drugs when they're in high school. Here's another example of how counterfeit prescription drugs increase the market for fentanyls. So this is actually kind of the analysis that really initially sparked my interest in this area. It's called Fentanyl, Heroin, and Methamphetamine-Based Counterfeit Pills, sold at tourist-oriented pharmacies in Mexico, an ethnographic and drug checking study. So this is while I was doing my PhD. I was doing this qualitative field work with people that use drugs in Mexico, and people started telling us in interviews and kind of coming to us and telling us, something is going on at the pharmacies, right? Like we're getting something from these pharmacies that seems stronger than it should. It doesn't seem like the oxycodone that I'm used to. And we actually went and used drug checking technology, and I'll show you some examples of what that looks like a little later, and actually tested a bunch of these drugs. So we were able to, these are all obtained, all these pills are photos of pills obtained from Mexican pharmacies and without a prescription in any case. So just walking in and asking for these drugs and seeing what we got, right? And so you can see it was relatively easy in this study for alprazolam or Xanax to be obtained without a prescription, but it was actually authentic in every case, right? It was easy to get. However, when we actually looked at things that were supposed to be Adderall, right, or mixed amphetamine salts, we saw that there were a number of examples of real Adderall being sold, and there was also a number of examples of counterfeit Adderall being sold that actually contained methamphetamine. And then when it came to the opioids, so there were numerous examples of authentic oxycodone tablets being sold, but there were also these counterfeit oxycodone tablets which contained fentanyl and even in some cases contained heroin, right? And so, which is very surprising to us. So what we ultimately found is that, this kind of phenomenon of the sort of small independent pharmacy, it's in Mexico, but all the sales language on the front is in English. It's very clearly directed for tourists. It says painkillers, Viagra, right? All these things, sleeping pills, and we found this practice of basically fentanyl and other synthetic drugs being packaged in pill form, sold, from someone who looks like a pharmacist who has a white coat on, usually to people who I think in many cases would not be willing to try fentanyl if it were, bought in a little baggie of powder on the street. The Los Angeles Times actually ended up independently verifying our analysis, and they went and did their own secret shopper study, analyzed a number of pills sold from pharmacies all over the country, and they actually ended up doing a whole series of articles and finding, a whole kind of world of really interesting findings. I'd recommend reading that series of articles. Entire bottles of pills, kind of sealed, but containing fentanyl, some really interesting things. So, there's a lot more, there's far more examples that I could share about counterfeit pills, but just to kind of bring it all home and summarize, the argument is basically that synthetic drugs, often in polysubstance formulations or kind of mixtures of different synthetic drugs, are increasingly packaged in counterfeit pill form. They're often indistinguishable from authentic pharmaceuticals. Sometimes they're really poor quality, right? They can be crumbly, like the pill press didn't work properly, or the person using it wasn't skilled. But sometimes they can be very, very convincing. And we argue that they really widen the scope of who is susceptible to synthetic drugs. And there's this inherent misalignment between the demand and the supply when it comes to counterfeit pills, right? It's sort of false advertising. It's kind of taking from all of the kind of social prestige and the kind of societal power that, a medication in a bottle has and kind of lending it to the illicit drug market. And here's some evidence of that, right? So you can see that only about 0.3% of students aged 18 tell us they've ever used heroin, right? But 5%, and this is kind of slightly older data where maybe there was more heroin around, but 5% at that same time reported using the recreational use of prescription pills, right? And so this is like a 15-fold gap between how likely is a teenager to use heroin, this kind of powder, form drug, or a pill form drug. Um, and you can see that that kind of really shapes, it kind of shows us how, stigma and cultural norms are extremely important in shaping what drugs actually get used and why. So it's not just about what is in the illicit drug market. When it comes to risk, it matters a lot what it looks like and how people understand it and interpret it. And as I said, this kind of the legitimacy of pharmaceutical products and establishments like pharmacies can be co-opted to convince tourists or convince anybody who would likely never purchase powder fentanyl into unknowingly, seeking it out and purchasing it. And I would add that I think there's a wide risk of people who are potentially exposed to counterfeit pills with a lot of connections to the kind of, medical system and the healthcare system. For example, one example would be chronic pain patients who can be, stabilized on chronic opioid therapy for a long time. Their doctor retires or their doctor changes or whatever it may be. They're no longer able to access this prescription, and then they go seek it out on the black market and they think it's going to be the same thing they're used to, and it's actually fentanyl. Or another example would be people who are seeking, medications for ADHD, or they're on them, lose access for whatever reason, seek them in the illicit market. And at least here in Los Angeles, that's almost always going to result in finding methamphetamine in pill form, and almost never actual Adderall. So I'll briefly cover some approaches to mitigate risk. I think that education and awareness actually have really kind of outsized impact in this area versus other parts of, kind of drug policy or other parts of the overdose crisis because of the inherent misalignment between what people want and what they're getting. It actually, I think education and awareness is always good, right? Of course, but here, if you actually inform people of what the illicit drug market looks like, you can potentially like really help them in a different way, right? Um, the other thing is that pill testing or drug checking services are taking off, and I think have a lot of value in kind of convincing people that they're not actually using what they think they're using, or just kind of even making them aware that this is a possibility. Um, Increasingly early warning systems are being developed to track pill contents and hopefully contain outbreaks before they fully take off. And then I think, there's a lot we can do as healthcare providers to kind of improve the clinical response to these really complicated with overdose syndromes and also withdrawal syndromes that are occurring. And that's a whole other talk, but I'll just talk on a couple, little points briefly. And then I think we, also need to understand the tension between cracking down on, some of the ways that pharmaceutical drugs are used, and then also potentially driving demand towards counterfeit pills. So, in terms of awareness and education campaigns, specifically for adolescents, there's been a lot of really good work happening across the country in terms of school and campus interventions. I personally think this is ideal when it's coupled with naloxone distribution and training. I've talked to many student groups about this because often it does require either a legislative shift or a school policy shift to be able to have naloxone on campus. It is a medication. Although it's very harmless for anybody who's not, physiologically dependent on opioids. But there's been a huge kind of movement to make naloxone more available as a medication that even, a teenager could potentially have to, save their friend, right? It can be very controversial, but also I personally support the idea of folks being kind of, even if they're not using drugs and would never use drugs, to be kind of recruited into awareness of this issue and also being able to potentially, as a bystander, save someone else. So I'll talk quickly about drug checking and pill testing. This is an area of, research interest for me. Um, and, it starts with the premise that even most people that are intentionally using illegal drugs often want to avoid the kind of strange, new, harmful things, right? That kind of want the thing that they're expecting to get, like any consumer. So, drug checking can actually empower people to shift their demand away from the most dangerous products and potentially use safer ones. So it's like harm reduction in that sense. There's a number of technologies here. So these are testing strips. They're a low-cost solution. They usually cost less than $1 per strip. They work in practice, they usually work on either the drug itself or on someone's urine, although there's a lot of nuances there. And you kind of have to check the specifics of each strip you would use. They have a lot of limitations. But basically it's one strip per substance, and the strip just tells you that drug is present or absent. It's a whole messy world, but something that I think is really useful to know, that if you're worried about xylazine, you can get a xylazine testing strip and you can give it to your patients, and they can pretty reliably know if it's in their urine or in their drug. FTIR, or Fourier Transform Infrared Spectroscopy, that's the machine that I've shown here. It's a more comprehensive point of care option. So here we are actually, testing a drug. This machine costs about $50,000. It can provide a readout in less than a minute of what's in this powder, as long as of anything that's 5% of the drug or more. So it's not perfect, but it's obviously much more information than just one testing strip saying this is or isn't present. And then there's gold standard testing, which is basically what I've used to show for all the kind of graphs and stuff that I'm showing you today, which is where we actually swab the sample, we mail it off to a big lab, they do mass spectrometry, and they tell us, kind of the gold standard way, this is everything that's in it at what concentration, what purity. So here's just some things that I think are interesting, again, from the Drug Checking Los Angeles project. And this kind of from the publicly available Viz tool that you can access at this link. And it kind of breaks down when you're expecting, based on what you're expecting, what did you actually get? So this is when people were expecting Adderall among 26 samples that the project has analyzed. You can see that in 90% of cases, people actually got methamphetamine, right? We see very little authentic Adderall on the street, at least in LA. It's all meth. And then you can see, a small number of people got ketamine or, MDMA, ecstasy, things like that. When expecting prescription opioids, this is among 80 samples, the picture is actually a little more complicated. So for whatever reason, about half the time, people were actually bringing us in, authentic prescription opioids, oxycodone. But 20% of the time, there was fentanyl. There was all kinds of other, strange things like xylazine, ketamine, heroin, all kinds of other things crept in, but you know, so it's maybe a 50-50 shot on this one. And then just to kind of highlight the point, this is when people are expecting fentanyl. So among 814 samples, you can see it was usually fentanyl, right? Over 90% of the time it was fentanyl, but there's this huge list of potential things that were added to the fentanyl. So people were, they're expecting just fentanyl, but they're actually getting, this massive list of potential things. Briefly, in terms of early warning systems, I think probably a lot of folks in the audience actually work in maybe some of the different kind of areas that can lead into an early warning system. Outbreak detection, the kind of gold standard for knowing what people die from is overdose toxicology, right? Where you actually test people's blood and tissues, mail it off to a lab in many cases. This can take months to get the accurate answer, unfortunately. And so for rapid outbreak detection, although this is really important, we need to use things like hospital records from emergency departments, emergency medical services records, drug checking, which is usually done at kind of community-based organizations, like I've shown, and then law enforcement seizures. And all this information can kind of flow in and help us detect, is something new and unusual popping up in the drug supply, popping up in counterfeit pills, and potentially leading to overdose deaths. So, very quickly, just talking about the clinical response, some kind of big picture things that I think are helpful is just again, education and awareness, counseling patients. Don't trust pills. I've personally met a huge number of folks who, will say things like, yeah, sometimes I buy Adderall on the street, right? Or whatever it is. Sometimes I get oxycodone. Just telling them, hey, like, that's probably fake. Here's a testing strip. Go get your stuff tested. Here's a community group that can give you more information. I think that can actually be huge. Kind of just helping people understand how rapidly things are changing. Um, is a whole other topic, but there is certainly some concern of overdoses that are not fully responsive to naloxone, given all the different synthetic substances that are out there. That being said, you still always want to give naloxone. It's very, very, very unlikely to actually harm someone. It's just that additional measures are also needed. Basic kind of monitoring of vital signs, transporting people for more advanced care is often needed now. And then really complicated withdrawal syndromes, where folks are having, because they're using such a high volume of, or such a high magnitude of opioids, withdrawal management is more difficult. There's a lot of other substances on board that people are withdrawing from, and withdrawal from different kinds of sedatives can be very complex, more complex than just withdrawing from opioids, can be life-threatening. Um, and so basically, these are just kind of areas of research where folks are studying how to kind of manage really complex withdrawal syndromes. Um, I think this can be really controversial, right? The tension between kind of the law enforcement approach of simply, or I should say the kind of the remove access approach, make it very difficult to access authentic versions of these medications that can subsequently potentially trigger, an addiction and people turning to illicit markets. But it's just important that we keep in mind that we have a large number of people that use controlled substances legally through the healthcare system. And we know from the past that anytime their demand is sort of, or their ability to access these medications is reduced, it's really helpful to have something else to fill the void so that they don't turn to the illicit market. And so this is where I'm a big proponent of getting people onto things like methadone and buprenorphine, kind of stabilizing people so that, the kind of crackdown on legal access to something can be paired with medical access to something safe as opposed to just turning people to the illicit market. Really quickly, I'll just say that this is also, we're really focused today on the United States, but the synthetic drug crisis, unfortunately, might be spreading to Europe and other parts of the world. And so I think a lot of the implications of what we're talking about today actually kind of touch the rest of the world, or may much more so in the future. So the Taliban, when they took control of Afghanistan again, actually banned the production of opium, um, which is the region of the world that has actually supplied, Europe and a lot of the world with heroin. And so like Europe has this really well entrenched kind of heroin market, heroin consumption. But there's unfortunately early signs that that is kind of changing a bit. And there's actually been kind of emerging data about the rise of fentanyls and a different class of synthetic opioids called nitazines, which is emerging in Europe pretty concerningly. Um, And we've seen a lot of the same things that we're seeing in the US, certainly on a much smaller scale, but we've seen them in Europe. So, for example, there have been counterfeit pills and even counterfeit vaporizers that contain xylazine that were found in the United Kingdom. Scotland has a particularly high overdose death rate, and there's been a very large presence of designer benzodiazepines in Scotland, and there's lots of other examples there. So these are my overall conclusions, and then would be very interested to have some discussion. So fundamentally, the overdose crisis has shifted as we've moved from agricultural to synthetic, and global drug markets are looking really, really different now. Counterfeit pills widen the target demographic. Um, I hope that this is kind of the one central point that you would take away from this talk, where people that would not normally buy a powder form of fentanyl, might be enticed to actually use pill form fentanyl because they're not aware of what it is. And just has less stigma. It just looks more trustworthy. In general, for anybody in the illicit drug market, expectations often no longer match reality. And, as drug checking data show us, people think they're getting fentanyl, but they're getting, 10 other things mixed with fentanyl, or they maybe think they're getting something that's an authentic pharmaceutical and it's really not. I would argue that we need to employ a lot of different strategies to reduce the harms of what's going on in the illicit drug market, scaling up surveillance systems, drug checking services, and appropriate kind of clinical interventions to help people get off of a lot of these substances. And then, unfortunately, there's a similar risk rising for a lot of other places around the world. So thanks so much for your attention. I really appreciate it, and we look forward to some discussion.
Thanks, Dr. Friedman. That was really comprehensive. So a lot of really great, important information. I know we have a lot of questions in the chat, but can we start with you talked about obviously the synthetics, the illicit synthetics. Are we seeing those? I know you mentioned in pill form. Are we also seeing those being vaped?
That's a really interesting question, and I would say um, there's plenty of reason to be worried about illicit vapes, right? Certainly, it's not as well studied of an area for various reasons. I will say like drug checking data is still it's a really new area. So the data that I've shown are some of the most comprehensive data, very new. We've got, I think, pretty good data about LA. We don't necessarily know what's happening in most of the country. And I'm not aware of studies that are doing a good job of testing, kind of black market vapes. Like it's just not something that is happening. I suspect that's because when most people are looking to get a vape, they're, often able to get it, at least where I am in California, through a dispensary where these things are pretty available. Um, I've seen some global examples of some very concerning things added to vapes, but these are sort of one-off anecdotes. So if you're on an individual basis saying, should I be worried about a black market vaporizer? I would say absolutely. Like that sounds like something that could potentially represent a lot of risk, but I don't have a lot of epidemiological data to tell you like the specific risks of that. But I would say that, in most of the country, I think it's relative. I think there's a lot of access to nicotine and cannabis vapes that, that there's other risks with the illicit market vapes, in terms of like lung disease. So I would broadly counsel folks to stay away from illicit vapes. If you have to vape, it's certainly pretty easy, I think, to get a real one.
All right, thank you. And can you talk a little bit? I know you discussed it, but what is causing the deaths when you have stimulants being used in conjunction with fentanyl and other
That's
opioids?
such a good question, and really complex. We're seeing this rise in stimulant involved deaths. And I like to always break it down by, is it stimulants with fentanyl or is it just stimulants, right? Or is it just fentanyl? We see this huge increase in the rise of deaths where it's fentanyl and stimulants. And I think in most of those cases, it's probably really a fentanyl death, right? But people like to use fentanyl together with stimulants for a variety of kind of a cultural practice, right? It's this thing that has taken off across the country. There's always been people that have used opioids and stimulants together, right? It's like a speedball, right? Is this thing that has always had a certain amount of, use, but it's just become much more common recently. And I could give you like a whole other, that's an area of a lot of interest of mine, but basically, I think when you're seeing in the numbers deaths from fentanyl and stimulants, it's probably really a fentanyl death among some like the thing that unfortunately ended that person's life was respiratory depression from opioids, but they happen to have some stimulant on board because they like to use stimulants too. We're also seeing a big rise in stimulant only deaths. That's a whole other area that's kind of interesting. Like, what is a stimulant overdose, right? I think an easy way to think about it is a lot of the time it's a stroke or a heart attack or kind of this massive surge of, kind of stimulant effect, right, that the body can't handle. But probably stimulant overdoses is a bit of a misnomer, and really stimulant deaths are a much more chronic, slower process that kind of just rapidly accelerates heart disease, neurovascular disease, these things that were kind of would have happened much more slowly. But yeah, very good question.
So I know you talked about the importance of awareness, right, and raising awareness, and that's one of the themes that we discussed throughout this learning series, right? The role that prescribers have, and the role that parents have, and all of the role that people in the community, right, community organizations have, and what we can do. So can you give us, just from your perspective, some tips on how to broach these conversations, whether they be with our parents, our patients, parents of our patients who may be looking for treatment. I mean, how young would you recommend that these conversations start? Just any information you can share on that.
Yeah, well, I think these are obviously really tricky talks, and I certainly don't intend to tell parents or pediatricians what's right for them or like for their child. But I do think, it's kind of important to have a pulse on what's going on. Like we know that a lot of the time counterfeit pills are sort of popping up in little hotspots. So I do think it's important to be aware of what's going on in your community. That can probably help, this audience is mostly, healthcare providers kind of understand what might be more or less urgent for any given talk. I think there's a way to frame these conversations where it's not like promoting a teenager to use drugs, right? And you also don't want to come in maybe or I would probably not want to come in, so intensely that I'm kind of, scaring them off from the whole conversation. I'd probably want to say something like, um, there's some really scary things out there right now. People might try them, right? Even though we definitely don't want them to. Some people in your school might try these drugs, right? And if they do, you actually might be able to help them if you know a little bit about, the signs and symptoms of an overdose. If you've heard of naloxone, you may or may not feel comfortable recommending that they, have naloxone. I personally think it's a great thing to like keep in your car glove box because you never know when you're driving by, somebody might be having an overdose in your community and you might be able to save them. So I think kind of threading that line of saying these things are out there in the community, they're just realities, and and none of these things are sort of intuitive. I think like there's no way that teens are just going to know what an opioid overdose looks like, right? It's just not something that is necessarily easy to understand or realistically portrayed often in the media. So I think just saying, somebody's breathing will slow down, they won't be breathing, right? Like their lips will turn blue, right? And so kind of just basic education, framing it in just sort of a certainly not promoting this, but just saying this is a reality that some people will do this, and you might be able to help them.
So I know we're coming to the end of our time. I do want to make note to all of our attendees that information on how to get your continuing education credits is on the screen right now. And Dr. Friedman, I'm just going to go to you with one last final thought. I mean, you shared so many important pieces of information, but and I know you've shared earlier what your takeaways would be, but one last note for people to take with them today.
Yeah, well, I'm just looking through the questions here, and I think that some people are saying, is there any way to like, tell if these, prescriptions are authentic or real? And I think, that's actually a very obvious point that I definitely should have said in the talk. A very key point that I should have said is basically the kind of key counseling here is like, unless you personally were handed, the pills, from the pharmacist, right, at a reliable pharmacy, you really can't trust pills anymore, right? That we have to kind of say, okay, we used to think that little bags of powder were kind of the highest risk category of thing, but now if you see, pills at a party, that's actually, red warning light should go off in your head. That's the highest risk category. And so there's definitely no safe way, even based on looking at the markings, asking AI, is this a real pill? Like that's not going to cut it, right? You might be able to detect the poor quality counterfeits, but there's very high quality counterfeits. So the real answer is, if it was prescribed to you by a doctor and, you or somebody trustworthy picked it up from the pharmacy, then that's safe. But otherwise, I would consider anything else to be in the highest risk category of illicit drug use.
All right. Well, thank you so much again for your presentation today and all of the information that you shared. I know as you can see in the chat, but it was really great information that we all can use in the work that we do. For all of those who joined us today, thank you. Thank you for your time. Thank you for taking the time to learn about this really important issue. And, as the opioid crisis continues to evolve, these are issues that, we need to know about, we need to be aware of in all aspects of our work. And next month, on May 14th, we're going to be talking about opioid screening, identifying risks and signs and symptoms. And I hope that you can join us on May 14th for that conversation as well. Once again, thank you, Dr. Friedman. Thank you for all of our sponsors today, and thank you for all of you who joined us. I wish you all a wonderful end to the month of April, and I hope to see you on May 14th. So have a good day, everyone.